Hello guys, we're going to have a chat about medical emergencies. This session is going to cover a number of different things from seizures, sepsis, anaphylaxis, sickle cell. We're going to have a chat about diabetes. So we're going to cover a couple of little bits in this. So the objectives, so the causes and treatment of common medical emergencies we're going to talk about, like I mentioned, seizures, diabetes, low sugars, high sugars, hypoglycemia, sepsis, anaphylaxis, and sickle cell crisis, which you may not have heard of. An overview of seizures. So seizures, there's many causes for seizures, lots of different ones. Everyone thinks it's, they're having a seizure because they have epilepsy or something like that. And epilepsy being one causative factor, there's many, lots and lots and lots. So they normally follow a pattern. Patient becomes unconscious, they have a rhythmic jerking of their limbs normally, sometimes there's no involvement. Patient not usually breathing as the muscles of respiration are compromised. They use a large amount of energy and are usually of short duration. So most of the time the common seizure presentations we get, the patient has an involvement of their motor nerves and also their sensory nerves. All of their nerves, all the neurons within their central nervous system are firing in a mismatched way, like in a lightning storm, basically like an electrical storm in their central nervous system. This inhibits information flow in the normal way that we do business and creates chaos. These are known as generalized seizures, and we'll talk about the different kinds in a moment. Pre-seizures sometimes, so before the patient actually has a seizure itself, they may experience what's known as an aura. And some patients experience an aura. An aura is like a precognition. So they have a feeling that they're going to have a seizure. Some of them know. Sometimes it's a smell. Sometimes it's just a sensation in their body. Sometimes it's colours. Sometimes it's sounds. The vast majority don't experience auras, but quite a significant amount of patients do. They will tell me, something like, I had a feeling I was going to have a seizure and I lay on the ground. This would be kind of commonish. Loss of consciousness tends to follow. Generalised muscle spasm, also known as a tonic-clonic or a generalised seizure. And area compromise due to trismus. Trismus being this clenching of the jaws. So when the jaws are clenched, we got what we call trismus. And this inhibits our ability to actually suction the oropharynx. And it actually inhibits our ability to get in, for the likes of suctioning and things like that. So we need to be very mindful of a patient if they are having a generalized seizure and they have this rhythmic jerking and the muscles, the masseter muscles of the face are locked up. We don't ever put our hands near the patient's mouth, okay? Putting things in their mouth is a no-no. I know in the old days we did stuff like that, but those days are gone, okay? You'll lose a finger, it's not good. Cause of seizure, so here's some common causes. So infections, particularly of the central nervous system, or infections that drive up temperature. Head injuries themselves, any kind of a head injury where we have an intracranial bleed or pressure inside here will in general lead the patient to seize. The brain does not like increased pressure, doesn't like changes in pressure. The cerebrospinal fluid around the actual central nervous system, the brain and spinal cord, is designed, one of its functions is to maintain uniform pressure around the brain. So when we get any kind of raises in the cranial pressure, the patient will tend to seize. Some of the other common things, hypoglycemia, so low blood sugars. So low blood sugars can actually cause the patient to have a seizure. And conversely, having a seizure and all of the muscles, a generalized seizure, all of the muscles rigid and shaking, burn huge, enormous amounts of energy. So having a seizure can induce hypoglycemia, and hypoglycemia can actually cause seizures. So all patients who have seizures, we need to check their blood sugar levels, because it's almost like if you see the patient getting onto every machine in the gym at the same time, they're burning off vast quantities of energy and they can drop their sugar levels very, very quickly. Intracranial bleeds, brain tumours, brain masses, head injuries, any of these things that put adverse pressure inside of the cranial vault will cause seizures. Epilepsy itself, so epilepsy is a chronic disease. Chronic means it's always there, normally treated quite well with medications such as Epilim, Epineutin, Keppra, and normally quite well tolerated. If people are having seizures and they're known epileptics, it's common to ask, how often do you have seizures? When did you have your last seizure? And if it's out of character, we need to dig a little deeper. Have you been sleeping properly? Are you under stress? Have you been ill recently? Because things like this can throw off the medication's ability to keep the disease under control. But it's important to dig a little bit with epilepsy, for changes in routine or changes of, patient lifestyle. Substance abuse, ecstasy in particular, polypharmacy being lots of different medications or illicit medications at the same time. Maybe febrile, so it may be a febrile convulsion, so maybe a small child having a seizure. One part of the central nervous system in the cerebrum is the hypothalamus, and one of the many jobs the hypothalamus does is it's like the thermostat in our body. It regulates temperature globally in the body systemically. Young children up to about the age of 3 or 4, the hypothalamus is not developed. It's an immature hypothalamus, and they tend to regulate big rises in temperature very badly. So large, big shifts in temperature, quick rises in temperature with children normally result in febrile convulsions or pediatric seizures. They can be one-offs, they can be, you can see a couple of them. In general, they tend to stop after the age of 3, but very common presentations. Substance abuse we mentioned here, one of the big ones that you would see would be alcohol withdrawals. Withdrawal from alcohol would be a common presentation for somebody to have a seizure. So maybe grand mal, generalized, tonic-clonic, so there's a couple of different names there. So generalized seizure, tonic-clonic. Tonic means with tone. And with tone, I mean with muscle tone. So let's have a bit of a look on the board here. So we have... So the tonic stage is when we're shaking, when our muscles have muscle tone, and the clonic stage is when they relax afterwards. Tonic-clonic, also known as a generalized seizure. Sometimes referred to grand mal, it's fine, they're terms. Generalized seizure, tonic-clonic, seizure with shaking. It basically means we have involvement of both motor and sensory nerves. So all of the nerves in the central nervous system are involved. If you're thinking about the central nervous system, I suppose these highways are we have an infinite number of junctions running through here. And if you could imagine, one of these junctions having a colloid of electrical impulses, what this would create would be absolute chaos, which means information doesn't flow across the neurons in and out of the central nervous system. We get chaos, almost like ventricular fibrillation. We get cerebral fibrillation, and we get this associated shaking. So this would be your generalized kind of seizure, yeah. One of the other seizures then would be your atonic. Atonic, so A means without, so without tone, also classed as an absent seizure, sometimes called perimal. So absent is a kind of the common term, and an absent seizure will be the one where you ask you guys the questions on a Monday morning, and you get to kind of that blank face, So we don't seem to have a huge involvement with motor shaking. However, we still have compromise of the muscles of respiration. The patient will look grey. They may very well look, again, like they have central cyanosis because they're not actually breathing. We still have the massive electrical storm going on, but we just don't have this huge connection with the peripheral muscle, the peripheral motor muscles, and all the shaking that goes with it. Some of the other ones we could have would be, again, we have the sudden rise in temperature, so febrile convulsion. Again, normally seen in children. Very common. Another one you may have would be maybe with the likes of eclampsia. Not very common. Eclampsia is to do with a lady who's pregnant. We talk about pre-eclampsia. Through eclampsia, you have massive rises in blood pressure. We have huge issues with this. Normally, in developed countries, pre-eclamptic ladies will be taken into the hospital sometimes for a couple of months before they give birth. They're normally induced early as well. So eclampsia, can throw off seizures and have huge repercussions for both the mother and the child. We'll talk about this a little bit more when we do obstetrics up the road. So we have a couple of different kind of types of seizure there if you want. Just briefly mentioned and just briefly outlined. So let's have a look. So status epilepticus is the other one that I need to mention to you. Status epilepticus is basically a seizure that lasts more than 5 minutes, or the patient has numerous seizures but does not wake up in between the seizures. Either of these things is called status epilepticus, and it means the patient is not coming out of seizure, and this is an immediate threat to life. They're burning enormous amounts of energy while they're seizing. They're not taking in oxygen. They're hypoperfusing globally, systemically, and cerebrally. So this is an immediate threat to life, status epilepticus. Okay, all caused by disruption of normal electric activity within the brain. So it's basically an electrical storm in the central nervous system. Okay. Post-ictal. So we have the pre-seizure stage, we have the seizure itself, and then we have the post-seizure stage, and we call this post-ictal. And post-ictal means after they start to come around. When they start to come around, they can still look quite waxy, very pale, they can still be a little bit cyanosed. Remember, they've been without oxygen and their fuel reserves are probably quite low, so they can be quite aggressive, very uncooperative. And it may take a number of minutes for this post-ictal state to kind of solidify and for them to ground and become, aware of their surroundings again and for you to start getting a bit of sense. They will be confused for some time. So checking blood glucose levels is very important. When we check blood glucose levels, we need to make sure that their sugars haven't dropped critically during the seizure. We can check their SpO2 because their SpO2 levels will most likely be low. Be prepared for another seizure. Sample history is very important. You may not get the information initially from the patient. We may get it from a bystander or a family member. However, we need to dig for the information. Okay, it's very important. Oxygen therapy, again, that's a really, really important thing. The patient may pull masks off. Initially, they may tolerate it and then pull it off and become aggressive. And we just be, repetitive and insistent and just hold the mask under their face and they'll push it away and just talk nice and calmly and quiet and make sure that mask is under them. Because even if they're getting, the blow by oxygen, it will take away this kind of foggy confusion for them pretty quickly. Okay, and it's quite important that happens. So what else we got? So there's a CPG associated for seizures. You need to know what it is. There's a lot of stuff in red over here, look. Sorry, my apologies. A lot of stuff in red here which you need to have a look at. Anything that's on here, this is your EMT version, you can be asked on, okay? So that's the reason why we're covering it. Every kind of medical emergency that we have a CPG for, we're going to have a bit of a chat about. Diabetes itself, we're going to have a chat about. So what is it? Diabetes is a problem with regulating sugars. Again, when it comes to cells at cellular level, we need to get fuel and oxygen into the cell. How do we do this? Again, if we're talking about the likes of cells as sponges, so if we're looking at a cell bed here, so what have we got? What we're going to have is we're going to have our arterial supply here, which is going to offer us, at this level, it's going to offer us some capillaries to feed these cells. On the other side of those capillaries, we're going to have the start of our venous system. And again, these veins start to head back through the organs of excretion and back to the pump. So we have our arterial supply giving fuel and oxygen, and we have our venous return. And within this actual watery environment itself, we'll have fuel and oxygen. And if we consider these, cells to have semi-permeable walls like sponges, water flows freely in and out. However, if we drop a marrow fat P in here, which would be, representative of a carbohydrate molecule or a glucose molecule, it won't actually go into the cell. It's not able to get into the cell. So the cells themselves, on the surface of the cells, we have lots and lots of little areas where we can interface. And on these interfaces, what we can get is a little hormone here called insulin. And what insulin does is insulin opens up a carrier protein. It opens up a channel so that these sugar molecules can actually go into the cell. So if insulin does not attach to the outside of the cell and open the door, then the cell doesn't get fuel inside. Fuel is left outside to build up systemically in the blood vessels and also in the extracellular fluid. Fuel can be circulating around the cell but unable to get in if insulin doesn't open up the channel. Okay, and this is an important thing to have a kind of an understanding of. So we take in starch. We take in starch from the likes of potatoes, the likes of bread, and this is our primary carbohydrate supply from rice, things like this. Yeah, it gets broken down into we have a storage of glycogen. Glycogen is basically usable energy. Glycogen is usable energy that's stored in the muscles and stored in the liver. It's almost like if you want a cordial, diluted cordial, when you pour it into the water, it permeates through into the cells straight away and it does not need insulin. It's a buffer to manage sugar levels. Okay, we carry glycogen in all of our muscles and also in our liver. We have a medication called glucagon, and glucagon basically opens up the doorway to release this glycogen so the muscles can use it. We use this as practitioners for people who have chronically low sugar levels, and what it does is it opens up this release of energy that's stored inside of the cells. So that's important to have a chat about with pharmacology, and I know you're going to be covering that yourselves. So let's have a look. Perfusion. Glucose, fuel and oxygen get into our cells, so the oxygen can migrate straight into the cell itself. But again, as I mentioned earlier on, the likes of our fuel. So we have our fuel. Fuel actually can't get into that cell there. What the fuel needs is, it needs insulin to open up a little channel so that these sugars can go into this channel and get inside of the cell to be used. So if we don't have insulin attached to the cell and the cell door doesn't open when the insulin actually interfaces with it, then we have a problem. We have a problem because we now cannot regulate sugars into the cells. Okay? So insulin is the key to unlocking this channel through the cell membrane. And it's something like this. So along the surface of all cells we have these protein channels. What we got is in our extracellular environment here, we got fuel molecules here and stuff that needs to come in. So basically what happens is we have our insulin. Our insulin actually interfaces here and opens this carrier channel up to facilitate fuel getting into the cell itself. Without that, we don't get fuel into the cell. We can't generate energy. So what's the story with the likes of this? What's the story with this insulin? So we're going to talk about a couple of types of diabetes. So if we're talking about insulin, what is insulin? Insulin is actually secreted in the pancreas. So you have an organ called the pancreas, which sits in your abdomen. Okay, it sits in your abdomen alongside your digestive tract. And what it does is it secretes insulin. As soon as we eat food, the pancreas secretes insulin, which circulates in our bloodstream. So as soon as insulin becomes available to the cells and interfaces with the cells, any available sugar gets gobbled up. So as soon as insulin becomes available, it opens the doorway into these cells, and all of a sudden all of this fuel gets gobbled up into the actual cells themselves, and it only leaves a few little molecules available for later on. So what happens is the fuel gets taken up and it gets used. Brilliant. That's in a normal healthy person. Somebody who has issues with diabetes has either a lack of insulin production or they have no insulin production. So we have an issue now with getting fuel into the actual cells themselves. So we're going to talk about type 1, type 2 and gestational diabetes. So type 1 diabetes is a complete lack of insulin production. So insulin does not get produced. The pancreas, the part of the pancreas that produces insulin, basically just stops working. End of. Some causes. So we have lots of causes for type 1 diabetes. It normally happens in childhood, usually after some kind of an idiopathic virus or viral infection or whatever for a week or two. Patient will be unwell, the child, and then we'll notice changes in their physiology. They start losing weight. They start losing weight because their pancreas has stopped working. When the pancreas stops working, what happens to all of the sugars that they have a meal, sugars build up, but they don't go into the cells because they don't have insulin attaching onto the cells to open up the doorway. So they start to lose weight, they start to get very thirsty because we have a large build-up of sugar around the body and in the body systems. The body is taking in lots of water to try and urinate a lot to get rid of these sugars. Okay? Cause of type 1 diabetes. So hereditary predisposition. So they know now that there's a hereditary predisposition to having diabetes. We tend to have diabetes in families, type 1 diabetes, where, I have a very close friend who he became an insulin-dependent diabetic at about the age of 11. His first son at the age of, less than 2 became an insulin-dependent diabetic after being unwell for a week. So there is a genetic link. Autoimmune diseases, so the part of the actual pancreas, the islets and Langerhans are the area within the pancreas itself that produces insulin. The body views it as a threat and destroys it. So autoimmune issues mean, autoimmune issues mean that parts of the body are viewed as a threat and get destroyed. That can be a problem. Unfavorable environmental factors, damage or removal of the pancreas, so drugs, chemicals or toxins, or endocrine diseases. So there's lots of causative factors. The other one that we can have is, so this is when we are not producing any insulin, our pancreas has sat down. Okay. So, no insulin is released when we eat, so what happens to circulating glucose levels? Here, this is what happens. We have a meal, sugars build up, but they don't go into the cells because we have no insulin attaching to the cells to open up the doorway. We have another meal, sugar levels rise higher. We have another meal, sugar levels rise higher, and the sugar levels just keep rising. So, people who are not producing insulin naturally, they have to inject insulin. If they don't inject insulin, their sugars rise absolutely enormously. Their baseline sugars are going to always be a little bit higher. So if we're talking about you're not producing insulin, you have sugars and they reach this level here. Normally, insulin gets produced and drops the sugars down because they go into your cells. These people here will always have higher levels of sugar because if they don't have high levels of sugar, they have very, very low levels of sugar. So hypoglycemia is a huge problem for these people. Their sugar levels are always high. And because they're always high, it's almost like golden syrup going around in their bloodstream. If their bloods are really, really rich in sugars, what's this going to cause? What kind of an issue is this going to cause? So, in the blood vessel itself, what's going to happen in there, do you think? We probably get a big build-up of gunge. Because the blood is thick and viscous and sticky, isn't it? So what's this going to predispose the diabetic to? All diabetics, their sugars are inordinately high because they're not sucking them in and using them. We're supposed to ingest fuel and then use it. And then ingest fuel, later that day or the next day and use it. We're not supposed to have huge amounts of circulating thick, gloopy blood in our body. So have a look at this. It's going to predispose them to, imagine these are arteries within your heart. It's going to predispose them to MI, to myocardial infarction. It'll predispose them to cerebrovascular accidents or strokes. It will predispose them to hypertension or high blood pressure because pressure is going to be high in the blood vessels. It's going to predispose them to heart disease. In the small blood vessels of the eye, it'll predispose them to the likes of glaucoma, retinopathy. In the kidneys, it will, if you can consider the kidneys like multiple layers of coffee filter paper, and then throw tons of coffee into it and clog it up. That's what's going to happen to their kidneys. The United States at the moment has roughly around 700,000 end-stage renal patients. So they have approximately 700,000 patients with kidney failure because of diabetes. Have a think about that stuff. Huge problems with diabetes is not just an issue with, my sugars are high or I have to inject insulin. This has major ramifications for your systemic health in years to come. So, chronic hyperglycemia problems, peripheral vascular disease, often leading to limb amputation when, diabetes was managed particularly crappy, which is not too long ago and still is in a lot of places. Small blood vessels in people's, legs in particular are not managed correctly. they ended up losing limbs, and they still do. Loss of vision due to retinopathy and glaucoma, which are, diseases of the eyes. Renal failure, I mentioned, may be predisposed to other autoimmune disorders, predisposed to MI, CVA, and cardiovascular disease. Absolutely. So this is not just an issue with, my God, my sugars are a bit high. No, this has huge implications for health. Type 2 diabetes, what is it? So it's lifestyle related, too much food and no exercise. We can use the doorbell analogy. There's an underproduction of insulin and an inefficiency of insulin. So if you think of it like this, you're type 2 diabetic. Type 2 diabetic ingest too much food. So when you ingest too much food, the pancreas keeps getting pushed. So you order a pizza, press the pancreatic button to deliver insulin to all the cells. So it needs to deliver a load of insulin. Press the pancreas button 3 hours later again for another big meal because you decide to have Chinese. We have another big release of insulin. Have another meal later on, another big release of insulin. And what we're doing is we're releasing huge amounts of insulin, which means that the cells that are receiving the insulin, two things can happen. Because we keep pushing the pancreatic button to produce insulin, the pancreas starts secreting less insulin, which means we have less of an effect on the cells, which means sugar levels sit high. The other thing it can do is the cells themselves may just become less receptive to insulin. So the insulin may actually be of poor quality. So, when it does actually bind onto the cells themselves, insulin binds on, it doesn't actually open the doorway because the cells are tired. They're tired of, insulin attaching all the time. So we have two issues here. We have insulin resistance, where the cells become a bit resistant to the insulin, and or we have issues with the pancreas secreting lower levels of insulin because we're eating too much food and pressing the pancreatic button all the time. Either, if we are ingesting, an absolutely enormous amount of fuel all the time, and it's not going into the cells, where is it going? It's going to sit in systemic circulation. It's going to sit in the blood vessels. It's going to sit in all the vessels. It's going to build up as gunge. It's going to sit in the extracellular environment. Either, we're going to start carrying it when we eat food. We're not going to ingest it into our cells straight away. We're going to put it on as fat. So we'll kind of carry a ton of weight, which creates other issues with the likes of high blood pressure and stuff like this. Either, you're type 2 diabetes, type 2 diabetic. Type 2 diabetic is mainly lifestyle related. Taking in too much food too often and not exercising, not using that fuel up, which means we put on a ton of weight. Our cells do not take up the sugars that we take in. We're taking in far too much fuel, which means our sugar levels are up through the roof all the time. Our baseline of 5 is probably about 9 or 10 in these patients. They normally get prescribed medications such as metformin, glucophage, diamicron, and what these medications do is they stimulate the pancreas to secrete more insulin, and they stimulate the cells to be more receptive to insulin. But either what you're buying is a stay of execution. This is not a cure to the problem. What you're doing is you're buying time. You're buying time to regulate your diet and exercise, and this will reverse your type 2 diabetes and put your system back online in a normal fashion. What do you think happens if we don't stop overeating and we don't stop exercising, don't start exercising? Our type 2 diabetes will turn into type 1 diabetes, where our pancreas fails. Now every time diabetic type 1 patients eat, they need to inject insulin. And you will never ever balance the amount of insulin to your food intake like your body does. So if we eat food and inject insulin, we need to make sure we inject a lower amount of insulin, that we leave some sugars in the body. Because if we take too much insulin, it's going to gobble up all of the available sugars and there's going to be nothing left. So with your type 1 diabetic, you've had a meal, you have your few cells here, and they gobble up most of those sugars. But we need to leave some sugars there. We need to leave a few sitting there. So, you know, we've had our meal, we've ingested our insulin, and we've gotten, you know, we've taken into our cells the majority of the sugars that we had circulating. And we've left a few of them there. And that's brilliant. So 5 or 6 hours later, the type 1 diabetic injects their insulin and they haven't eaten. And as soon as we, you know, get insulin into our system, all of the cells become greedy. And what they'll do is the few little bits of sugar that's left from our last meal are going to get gobbled up really quickly, aren't they? And what's that going to leave now? What's that going to leave for upstairs? What's that going to leave for our brain when these sugars get taken away? It's going to leave absolutely nothing. And we have what's known as a hypoglycemic emergency. So the few sugars that are there get gobbled up, there's nothing for upstairs, and the patient collapses into a hypoglycemic coma. That's one cause of a type 1 hypo. Or another cause would be if somebody's got, if they go out and they expend more energy than they usually would, and they haven't eaten, then obviously they're going to use up any available sugar and they're going to hypo down as well. The other thing is if they have maybe the likes of a serious illness, where, you know, their body is fighting infection and using a lot of fuel, they can hypo down. If they get a bad dose of vomiting or diarrhea, they can hypo down. But like, I mean, sugars that are high will always stay high for long amounts of time, but sugars that go low very quick. So diabetics, particularly type 1 diabetics, who are unconscious, we would tend to suspect a hypoglycemic event if it was a sudden onset, and we need to always check their sugars. So type 1 diabetes, pancreas no longer works. Every time they ingest food, they need to inject insulin so that this food can get into the cells. Okay? If they take insulin and don't eat, they will have a hypo event and they will go low very, very quickly. If they're not high, so we normally have sugars of about 5. Our sugars are normally about 5. Their sugars are probably about 10. If they're not high, then they're going to be low, and they need to be high rather than low. Okay? Type 1, they don't secrete any insulin whatsoever. Type 2, they secrete bad insulin or not enough insulin, which means, again, we still have high sugars. Type 2 diabetics who don't manage their lifestyle will become type 1 diabetics. So, is this preventable? Absolutely, it's preventable. It's also reversible, which is really important. So risk factors for type 2 diabetes: lack of exercise, overweight, family history, and unhealthy eating. Eating crap all the time, too much in, not enough out. Simple as. Type 2 diabetes likely to have comorbidities. Comorbidities mean other problems with their health. High blood pressure, high cholesterol, heart disease, predisposed to MI, predisposed to CVA. They're going to be obese, probably have COPD. They will have a lot of stuff going on with their health. Okay. Treatment, diet, exercise, it's reversible. Yeah. Progressive potential to type 1. If they don't do anything about it, the majority of people are progressing to type 1. This is where we're getting our biggest cohort of type 1 diabetics now. It's people who are just lifestyle related, overeating, not exercising, become type 2 diabetics, and they don't do anything about it and they become type 1. Medications, common medications include glucophage, metformin, diamicron. Absolutely. Anything else to note about that? Summary of type 2. Type 2 diabetes is underactive or inefficient insulin production. Causes include chronic increased demand on insulin production in the pancreas because we're overeating and we're not exercising. Cellular resistance to insulin stimulation of protein carrier channel. It won't open the doorway to let sugar in because the cells are overstimulated. Leads to ineffective volume production or ineffective insulin. So that's what type 2 is. In the likes of the Middle East in particular, the likes of the Gulf states, like the Emirates and places like that, they've had a major lifestyle change in the last 50 years. 50 years ago, your typical Arab in the Gulf states, like the Emirates and that, would have been eating lean meat, would have been exercising most of the day, pearl diving, walking. Now they drive 4x4s and they eat Colonel Sanders stuff. They have huge problems with diabetes. Your typical lean Arab is now overweight. A dish dash is 10 yards, 10 yards a dish dash, and particularly during the likes of Ramadan, where they don't eat between sunup and sundown. You know, they have huge problems with hypoglycemic events. They're driving these 4x4s at speed on highways, and the car crashes are epic. You know, unbelievable stuff. Treatment for glycemic emergencies: hyperglycemia, slow onset. Signs and symptoms. So how will they present? They present quite confused because they don't have enough sugar getting into their cells. Remember, the sugars are really high, thick and gloopy. They're not getting sugar into their brain, so they're going to be, you know, a little bit off. They're going to have an altered level of consciousness. They're going to be very, very thirsty because they're going to be urinating a lot to try and dump some of the sugars. Okay. Supportive care of patient symptoms. You know, hypoglycemia, you know, that's the one we're really worried about. Acute onset, happens really quick. Signs and symptoms, you know, changes in level of consciousness. Patient can be unconscious. Snoring is quite common. Check the sugar. Sugars are low. Remember, they're hypoperfusing. They're not getting fed. This is an immediate threat to life. Hypoglycemia, hyperglycemia, yeah, massive problems, all right. But again, you know, much slower onset. Hypoglycemia, acute onset, cerebral hyperperfusion. Check blood glucose levels. Okay, always check AVPU. You know, if they're, you know, alert or verbal, we can give them the likes of our sugary paste. If they're P or U, pain or unresponsive, then we will probably give them glucagon to release the glycogen stores in the body that I mentioned earlier on. And again, in pharmacology, we'll discuss this. Have the patient ingest carbs or sugar. V or P, consider glucagon. U, supportive care, glucagon and oxygen therapy. Glycemic emergency CPG, you should be familiar with. There's a little bit going on with it. Anything again in green is for you guys. Glucose gel, glucagon 1 milligram for an adult, 0.5 milligram for a child. This is something that we will cover in our pharmacology. Sepsis. So what is sepsis? Sepsis is the body's response to infection. So we can have an infection in the body and it's not a huge problem. The huge problem is our body's reaction to this infection. If the body perceives this as a massive problem, this is where we get the issues. Okay. So sepsis, so origins of infection. Infections are bacterial, viral or fungal. Common sites of infection will be respiratory tract, urinary tract infections, cellulitis or intra-abdominal. Respiratory upper or lower respiratory tract infections, urinary tract infections. Cellulitis is infections in the skin, normally people with diabetes, people with heart disease. Intra-abdominal, the same kind of stuff. Urinary tract, you know, lots of causes for that. Not being able to void all your urine, very common in the older population. Enlarged prostates in males inhibit their ability to actually empty their bladder, and you know, stagnant urine that sits in the bladder becomes infected. Respiratory again, you know, where, you know, every year from September onwards is kind of, you know, respiratory tract infection season. You know, October, November, December, it's very, very common. Sepsis. So sources are all listed here and you can have a look at them yourselves, guys. I've just discussed them. Patients at risk, the elderly and the very young. Always, always, always the elderly and the very young, the elderly in particular. Okay. Immune compromised patients, HIV, cancers, comorbidities, people who are obese, people who have diabetes, people who have heart disease, COPD, you know, multiple problems with their health. It means a multiple load on the system's ability to do business. Some antipsychotic medications, clozapine and risperidone, reduce immune response, and that's nice to know. But some people are much more at risk than others. So, what are we talking about here? So, if we're talking about the likes of sepsis, if we get a small cut in our arm, how would we expect this arm to actually to look? You may get a small area which has become red and inflamed. It'll be quite hot to the touch. Why is that, do you think? What do we need to get into this area here to kill infection? So what we'll probably need on scene is some white blood cells. Which obviously kill infection. They kill these pathogenic organisms. What we truly need is, so here's our blood vessels. Our blood vessels are made of cells, normally nice and tight like this. We have our wet bits of blood, which is our plasma, and we have our dry bits or solid bits like our red blood cells, which carry oxygen and hemoglobin. We have our white blood cells, which fight infection. We have our platelets, which form plugs for bleeds. We have hormones, we have fuel, we have oxygen, we have waste products, We've everything circulating within this. What we need to do in this area of the arm where the local infection is, and we'll use the arm as an analogy, is we'll need to get a lot of white blood cells in situ pretty quick. And the best way to do that is to dilate these blood vessels so that they're nice and wide to bring a big flow of blood to the area. In the area itself then what we'll have is we'll have a migration of white blood cells out of the blood vessels into the area of infection outside here. And it's going to fight the infection. Yeah. What we'll also get is maybe a little bit of the wet stuff, a little bit of plasma coming out here too, and we get a little bit of swelling. And that's why we get swelling, that's why we get redness, and that's why we get heat in a local area of infection. So what happens if this is an area of our lung that's got an infection and we have this inflammatory response going on? What else is going to happen? Well, what may happen is if some of this infection gets out of the area and starts to circulate and it's only a small amount, we can get chemical messengers ringing a bell around the body. So it may actually go from here to other parts of the body where we get this big vasodilation and we have this big problem with this inflammatory response. So there's a number of different things happen during an inflammatory response. But one of the big ones is we get blood vessels dilating like this. And globally then, as I mentioned before and we discussed before, we've got maybe 5-6 litres of circulating blood. But we potentially have 12 litres of space if we dilate everything simultaneously. So if we have a lot of vasodilation around the whole body that doesn't need to be happening, blood pressure is dropping, we're not able to concentrate white cells in areas where infection truly is. We can get small little clots forming in small blood vessels in internal organs. We can get internal organs failing. This is what our sepsis, this is what our inflammatory response is. This is what happens. Remember, if we have big vasodilation around the whole body, we now have septic shock, which means we now have a drop in blood pressure. So now what we have is we have sepsis, but we also have the start of septic hypoperfusion. And this would be catastrophic to the patient. Sepsis deaths around the world are absolutely enormous. In the UK, they reckon, the British Sepsis Society reckoned in 2016, they reckon they spent 20 billion with associated costs for sepsis alone. Sepsis is not of one origin, it's the body's response to an infection. It's not necessarily the infection that kills the patient. So this is an important thing to understand. So one of the easy ways that pre-hospital practitioners have of having a look at sepsis is we have a look at this thing called SIRS. So SIRS is Systemic Inflammatory Response Syndrome. So what we do is we look at the patient and we see if they have any inflammatory markers. Because when we get this inflammatory response, we have certain things happening within the body. Okay. So signs of SIRS. So temperature less than 36 or greater than 38.3. So the patient's temperature is either rising because they're fighting an infection or they're going cold because they fought the infection and they're losing. So a cold sepsis is probably somebody who's going to die. A hot sepsis is probably a far better thing to be seeing. Heart rates of above 90 because the pump is circulating in volume as much as it can to try and fight infection. Respiratory rate is above 20 because the body is trying to ingest as much oxygen as it can to give to the cells to fight the infection. Acutely confused. So the patient can be confused because we've got cerebral hypoperfusion going on and we've got a wildfire agent throughout the body trying to fight this infection. Glucose levels greater than 7 if they're not diabetic. Why is that important? What is the body trying to dump? It's dumping as much fuel as it can. When you have a bad infection for days, you'll see people literally wasting away in front of your eyes. The body is dumping everything it can, fuel-wise, into the bloodstream with as much oxygen as it can, so the cells have the energy to fight infection. Okay. So has the patient 2 or more of these in the presence of a suspected infection? Because if they do, they're now SIRS positive, which means that we consider them to be septic until proven otherwise. Pre-hospital practitioners tend to use this quite commonly and will diagnose sepsis far more commonly and far more efficiently and effectively than a GP because GPs are thinking different things. It's quite simple. Just keep putting the framework on it. Are they SIRS positive? Do they have 2 or more of these markers? And do they have signs of an infection? If they do, then they're septic until proven otherwise. And it works quite well. Sepsis is a potentially fatal response by your body. Systemic inflammatory response syndrome is an inflammatory state affecting the whole body. the body becomes globally on guard because it believes that the infection is systemically going to kill them. It may not be the case. It may just be a small infection in a certain part of the body, but the body's reaction to it is what does you in. If 2 or more SIRS markers are present with severe infection, then the patient is septic until proven otherwise. Okay. Sepsis with signs of shock, i.e. poor perfusion, septic shock, hypoperfusion. So SIRS positive patients are septic until proven otherwise, particularly if they've got blood pressures below 90 systolic, heart rates over 90, respiratory rates over 20. Think of what's going on here. They're in compensatory shock, and they'll only compensate for so long, particularly the elderly, who are the most susceptible to sepsis. End organ impairment, if we get big vasodilation around the body, our organs don't get perfused as they should, particularly the likes of your kidneys and your liver. And once they shut down, the patient is on their way. Okay. So treatment, we have a sepsis CPG for adults here. Have a look at it. So SIRS is mentioned in here. We're talking about giving patients paracetamol, which you need to know. Talking about meningitis. Talking about give 3, take 3. We need to be very, kind of up to speed on this CPG. There's a little bit going on in it. And again, anything in red is something that they tend to ask questions on. Okay, have a read of it, guys. We're going to talk about allergies pretty briefly. What's an allergy? And I think about allergies a little bit kind of similar to inflammatory responses. So an allergy basically is a reaction by the body's immune or defense system. It's designed to prevent pathogens which will cause harm entering the body. And again, it's a little bit kind of similar to your body's perception of what's going to do it harm. Some people have hay fever. They have an allergy to pollen. So pollen is just something that sets off a big response within their body. It doesn't mean that pollen is actually going to kill them, but the body perceives it as a threat. So, how do we get stuff into our body? We can breathe it in. We can get it into our mucous membranes. We can ingest it by eating it. It can get in across our skin transdermally. We can get injected by the likes of insects or stings. So we've lots of different ways of getting, antigens into our body to cause problems. Common ones would be stuff like pollen. So what happens when we have a pollen allergy and the pollen is high? Patient rubs their eyes. They get a lot of mucus production. They cough and they sneeze. The mucus is there to catch the pollen on the way in. The runny eyes is there, the mucus, to catch the pollen on its way through the mucous membranes. And that's fine. And that's a pretty mild reaction. We may get a sting of the likes of a nettle sting, and we get a little bit of raised rash, a localized raised rash on the skin. And it stings for a while, and a few hours later it eases off and it goes away. And they'd be mild reactions to an allergy, which is fine. But we may also get much more severe responses. A moderate response is something which would involve more than one body system. Some people who have the likes of hay fever or pollen, in pollen season, they may actually get the likes of asthmatic attacks. They may get an asthma attack out of it, because not only do they get the sneezes and the sore runny eyes with the grit in them, and they may then get a constriction of their bronchial tree, because the body is saying, "Whoa, hang on a minute, we need to tighten this bronchial tree down to stop stuff coming in, because we're breathing this in as well." And they can get very tight, wheezy lungs, and that will be considered more of a moderate reaction, because we now have involvement of the respiratory system, as well as other reactions. So we'll talk about that. So common allergens: dust, animal hair, animal dander, dogs, cats, feathers, all very commonly cause allergies in young kids. Pollen's a big thing. Nuts, eggs, fish, medications. Certain medications can be quite hairy. A lot of penicillin-based medications can cause problems for certain people. And just because you haven't got an allergy to anything right now doesn't mean you won't develop an intolerance later in life or in your next Chinese. So you need to be mindful of this. Body's reaction to allergens. So the body will try to stop allergens entering, and it will, exactly like we discussed. It will produce a lot of mucus in the upper end, the likes of your nose and your eyes. It can constrict your bronchial tree. If you're ingesting something like a Chinese with some stuff in it that your body thinks is bad for you, you may vomit and get diarrhea as the body tries to expel, what it considers to be a threat. How else might it actually just, thinking about it, how else would it stop allergens entering or circulating your body? So what do you think it would do to your digestive tract, to that conveyor belt as it's moving along? You know, a lot of the time it will just stop it in its tracks, so your digestive system can just be kind of stopped. Your heart rate can be slowed down. We can get bradycardias with a serious reaction to an allergen, because the body, by slowing the pump down, slows down the circulation of the antigen around your body. Okay. Sneeze mechanism, running the eyes, bronchospasm, vomiting, diarrhea are also help expel allergens. So this is what the body will do naturally. Okay. An allergy cascade. So, you know, just because we get a snotty nose or runny eyes doesn't mean, you know, that it's going anywhere. It's only when, you know, it gets into the bloodstream and starts to circulate that the alarm bells start ringing. Okay. Allergens are viewed as a threat by the body's immune response. And how the body signals that there's a potential invasion is they use these things called mast cells. Mast cells are involved with immune response. They lock on the allergen, and if viewed as a threat, they degranulate. And what this is almost like in my head is, I consider them almost like balloons full of talcum powder. The balloon gets burst, and that talcum powder, which is full of chemical messengers, gets dumped into the bloodstream and circulates quickly around the body. Because it's circulating around the whole body, we now have a systemic response. So we have a response maybe within the cardiovascular system. We'll have a response potentially within the respiratory system. So this is where we can have the likes of an allergic reaction that becomes a severe allergic reaction. And this can be a life threat. Okay. So mast cells, they'll lock onto what they consider to be a potential invader. If it considers, there's the allergen there, it grabs a hold of it here, and if it considers it to be a threat, all of these ports will open and all of these chemical mediators will be dumped. These are your histamines, and there's lots of different kinds of histamines, which then go and lock on to various sites around your body, eliciting a response to try and neutralize what it considers to be an invading allergen. Okay. We can have kind of mild, moderate, or severe reactions, and the majority of people only ever experience mild reactions, you know. So, you know, common cause of anaphylactic reactions. So allergies versus anaphylaxis. So an allergy is when we get the sneezes or our body doesn't like something. But when we start getting an anaphylactic reaction, this is when we get degranulation of mast cells systemically going around the body, ringing the bell saying we have a problem. Okay. Common stuff: peanuts, walnuts, almonds, Brazil nuts and cashews. Fish and shellfish are big. Penicillin and other medications. Dairy products and eggs. Insect stings and bites, very common. Soy, sesame, latex is one actually that causes a lot of problems as well. Any of these things here can set off a chain of events that, if we have, you know, these mast cells locking on and considering these a threat, can cause chaos in your body. Body's reaction, lots of different ones: swollen eyes, risk of unconsciousness, swollen mouth or throat, wheezing, difficulty breathing, nausea, vomiting, itchy skin, lots and lots of different ones. Okay. Mild, moderate and severe, and the CPG splits it into 3. Okay. Mild is like urticaria only, and when we're talking about urticaria, they do love their big words. Urticaria we could just call a rash. Okay. Urticaria is a rash. Urticaria, again, is your rash. With edema is swelling. Bronchospasm, you know what that is. Spasming of your bronchium. So what's going on here, if we're talking about edema, you know, we're talking about swelling. So what kind of swelling? Urticaria with edema and bronchospasm with airway, breathing and or circulation compromise is severe. So this is affecting a number of body systems simultaneously. And when this happens, it happens very, very fast. So what happens is we get a systemic vasodilation. Sorry, my apologies. So what we do is we get this this big vasodilation where our normal blood vessels here are nice and tight, and all of a sudden they become big and leaky. And because they become big and leaky, what we get is we get a leak of fluids as well as everything else out of them, the fluid being plasma. When we have fluid leaking from the vasculature around your body into these adjacent areas, we get swelling. If we get this around the face and up around the airways, this can compromise our airway very quickly, and this will be a sure sign of severe anaphylaxis. And this is quite severe. It kicks up literally in minutes. I've seen a few of them. The primary, we'll have a look here. Here's a mild reaction here. We'll have a bit of a chat about this. So have a look at that. So that's somebody who's got maybe a nettle sting. And you can see the redness on the skin here, look. And this redness is basically vasodilation. It's the blood being taken to this area so that white cells can deal with this potential allergen. We have swelling, a little bit of swelling. If you touch it, it's kind of swollen. You can see it here. And this is where plasma has ran out basically with the white cells into the extracellular environment, swelling the tissue a little bit. And it's fine when it stays there. That's not a problem. This is subcutaneous edema, so this is your swelling. Local reaction. So histamine causes the vessels to become more permeable. So it allows these fluid shifts, which is bad. Okay. Moderate reaction, picture your patient wheezy with an itchy rash, usually with some swelling. Can be found anywhere, not just at the site of the invasion. So, because we got histamine release going on around the body, we can have this vasodilation happening sporadically around the actual body itself. Okay. Swollen hands and feet are very common signs. It's on the face or mouth. We need to be thinking about the potential for airway compromise. Wheezy is a problem because now we have less circulating oxygen in the body and the patient's going to be struggling. This is a problem. When I see a patient with a moderate reaction that's wheezy, I'm thinking this could go sideways, it could go all the way, and I'm very, very careful about how I treat this patient. Okay, there's a moderate reaction, and again we have a pretty big body surface area there. The initial irritation may actually be somewhere down on the leg, and we get these areas breaking out all over the body because histamine is circulating around your whole body and it's creating this inflammatory response. Severe reaction is an extremely sick patient, and you definitely won't miss any of the signs. The easiest thing is to look. This tells you everything. Have a look at this girl. She's had huge amounts of fluid shift. It's on her face. Her eyes are swollen shut. You got huge edema here on her face, down her neck as well. This child is like seriously ill. And it's not going to be an hour or two with some medication to get rid of this. This is going to take days for everything to go back where it's supposed to. And this is a very sick patient. And they can get into this state literally in 3 or 4 minutes. I've seen it. It's unbelievable. You have an anaphylaxis CPG and there's a lot going on. And you need to be quite au fait with this. You have chlorphenamine oral, you have chlorphenamine intramuscular. Epinephrine 1 in 1,000, tightening up those leaky blood vessels, makes them blood vessels nice and tight again, speeds up the heart rate. This is your frontline defense. Against anaphylaxis is epinephrine, if you consider it to be a severe event. Your chlorphenamine, by giving them chlorphenamine, it's an antihistamine, so it stops these histamines from locking onto cells when the mast cells degranulate. It stops it at source. Okay. What else can we give them? We can also give them maybe some salbutamol to stop bronchospasm if that's there. So that's 3 medications all of a sudden that you'll be looking at, working out dosages and giving to these patients. You'll be thinking about your advanced life support because they're going to need other stuff. We have a ton of drugs that we can give. We can give actually everything that they're going to get in the hospital. And we do. And even at that, like if you trash your bag and you give all the drugs to the patient, even then it's in the lap of the gods if you get stuff in quick enough because they can go downhill that quickly. Okay. The last thing we're going to talk about here is sickle cell. Sickle cell, misshapen crescent-shaped red blood cells. It's endemic to certain populations. There's a genetic predisposition and it can lead to what they call a crisis. So the certain populations we're talking about are sub-Saharan Africans. So black people, it's a genetically passed on thing. And at certain times, the red blood cells that are almost like, those big donuts with the hole in the middle, and that's the way our red blood cells should look. They don't look like that anymore. They start looking like a crescent moon. So they start looking like these. And because they start looking like these, have a look at the misshapen blood cells. It should be nice and donut shaped like this, but you get these things here. So if we get these, there's a couple of things going on. The first thing is our ability to carry oxygen is greatly reduced, so the patient becomes hypoxic very quickly. It depends on the amount of misshapen or sickle cells, red blood cells they produce at this time. If they produce an absolutely unbelievable amount, we can have what they call a crisis. And a crisis then will involve a couple of other things. So, a clumping of red blood cells. If we have a lot of these misshapen blood cells coming together in small blood vessels, it can actually block the blood vessel and form a thrombus. Okay, it can form a clot. And this is a major problem, particularly in small blood vessels in internal organs like the spleen. Most of these kids, if they live in third world countries, they'll be dead before they hit kind of teenage years. If they're in first world countries, it's quite common for them to have their spleens removed, have a splenectomy because of these emboli, which will form in the likes of their spleen, their liver and other places. And if they have their spleens out, they're then on prophylactic antibiotics for the rest of their lives. Usually the clumping will happen in joints or solid organs like the spleen. It forms a clot or an embolus, very much like an MI, where because of the misshapen blood vessels, they just block up blood vessels and everything downstream starts to starve. Maybe an immediate threat to life, very, very painful. Very painful. Had quite a few of them here now, particularly kiddies presenting to us. And there seems to be a huge a stigma attached to this where they don't want to tell you they have sickle cell. There seems to be like a stigma attached to having sickle cell for whatever reason, I don't know. So, have a look at it here, look. See the clumping that's happening in this small blood vessel here? And what you've got is, it's all backed up, which means everything downstream here now is starting to die, starting to become ischemic and starting to die. Okay. What we need to do is to break these clots up. So you really need advanced life support either on the street or in the hospital, because we need to give lots of fluids to break up this clumping. It'll be very painful, so the patient will need some pain medication. Okay. And they'll also need oxygen, because these misshapen cells, their ability to carry oxygen is greatly reduced, so they're going to be hypoxic anyway. Okay. So here's a typical hand of a small child with sickle cell. Have a look at the swelling. You can imagine the pain this child is in. Okay. Your methoxyfluorine will work quite well for this. Your advanced life support will give other medications as well. So if you can get ALS, brilliant. If you can't, these kiddies in particular, need to go to child hospitals. They're normally treated in the likes of Our Lady's Hospital in Dublin, also in the likes of Temple Street and some of the paediatric units around the country, but they need to be looked at pretty quickly. Because this is if they reach crises, if they have a huge volume of red cells that are misshapen, it can kill them. Treatment is pain medication, oxygen therapy and advanced life support, be that on the street or in the hospital. Doesn't matter where. So it's either diesel therapy to get them to the hospital, or if you've got ALS available, happy days. Again, immediate threat to life, particularly if it's crises, very painful, and oxygen therapy is a must. Few questions. If you have them, we'll have a chat about them in class. Have a look at the CPGs, guys. Have a think about what's said in this session. There's a little bit in it.